Okay. Good morning, you guys. Okay. Today I'm gonna talk about basic hemodynamic data recorded in cardiac catheterization laboratory. Again, I would like to introduce myself again. My name is Papum Danjitisli, and you just can call me Math. And I am a cardiac technician or cardiothoracic technologist at Cardiovascular Center, Julapon Hospital. I have 4 years experience about in the field of cardiac catheterization. But before that, I used to work as a EP technician. Okay, well, let's get started. The first thing I would like you all to know about the basic hemodynamic, you're gonna have to understand about the basic anatomy and physiology of the heart. Well, just get through this topic just briefly to get the basic idea about the hemodynamic within the heart. Okay, well, start with the blood, which is the oxygenated blood from superior vena cava and inferior vena cava, and then the blood will go back to the heart to the right atrium, which is the first chambers, will collect all of the oxygenated blood around the body. After that, the blood inside the right atrium will be contracted into the right ventricle through a valve, which is called tricuspid valve. After that, the blood in the left ventricle will be pumped out into the pulmonary artery through pulmonary valve. After that, the blood will go to the pulmonary, the sorry, will go to the lungs, and then will exchange the oxygen there. After that, the blood will comes out of the lung with oxygenated blood. After that, the blood will go back to the heart again into the left atrium through 4 pulmonary veins, right? The blood in the left atrium will travel down to the left ventricle through mitral valve, and the left ventricle will pump the blood out again into the aorta through the aortic valve, and the blood in the aorta will be able to travel around the body just like as and cause the systemic circulation. Okay, this is just a basic step of the blood flow within the heart. Actually, you should know more about the cardiac cycle. I mean about the phases of cardiac cycle, um, because when you study about the intracardiac pressure, sometimes you need to understand deeply about the detail of that activity in order to be able to diagnose the abnormal pressures or anything that happen in the laboratory. So I'm gonna start with in the phase of the diastole. Okay, let's say about start with the PVEF. Okay, uh, actually the PVEF refers to the atrial contraction, right? So at that phase, the ventricular is on the phase of the ventricular filling. Okay, after at that phase, the ventricular filling will be at the diastole, right? The diastole. So during the ventricular filling, the tricuspid valve or mitral valve will open in order to let the blood inside the atria go down to the left ventricle. And after that, after the blood goes down from the atrial to the ventricle from the difference of the gradient. After that, the atrium will contract and pump the rest of the blood out into the ventricle again. So this is the end of the diastole phase of the heart. And after that, after all the LV or the RV, I mean about the ventricle, will try to build the pressure again in order to pump the blood out into the aorta. So it will go to the isoverometric contraction. I mean, at this phase, no change about the volume, but just the pressure changing in the ventricle. You see this? Okay. After that, after the ventricle can build the pressure higher than the aorta, the ventricle will eject the blood out into the aorta. And this is the end of the systolic phase of the ventricle. And then go back to the isoverometric again, but not contraction. It will change to be isoverometric relaxation that can describe about the ventricle is in the phase of try to reduce the pressure in the ventricle in order to make the pressure in the ventricle lower than the atria in order to be able to get the blood from the atrial by the difference of the gradient again. For this slide, I'm gonna show you about the relationship between cardiac cycle and electrocardiogram on the EKG. I just want to now show you about the activity of the chambers with the relationship to the EKG. Okay, for this is a diagram which is called Wiggers diagram that will show you about the activity of the pressure in each chambers. For this diagram is showing you about the LV pressure, LA pressure, and aortic pressure, definitely with the relationship with the electrocardiogram on the top of the diagram here. Let's get started with this at the P wave again. Okay, the P wave refer to the atrial contraction, right? Of which is the, let's say, about the end after atrial contraction, the blood from the atria will go to the ventricle, and which is which means the atria will pump out the rest of the blood in the atria into the ventricle, which is the final diastole, right? After that, after blood into the left ventricle, the pressure in the left ventricle will increase, and then the pressure after the pressure is equal to the atrial, the pressure in the left ventricle will slam the mitral valve or bicuspid valve to close. And at this phase, at this line, at the phase, all of the valve will be closed here. And during this phase, we call isoverometric contraction. So during the phase, all of the valves are closed, and in this phase, the ventricles will try to build the pressure inside the ventricle in order to be able to get the higher pressure. I mean higher, more than the aorta, in order to be able to inject the blood out into the aorta. So after the ventricles try to build up the pressure inside itself without any changing of the volume, just change the pressure inside. Okay, at this point, after the pressure in the ventricle is more higher than the aorta, the ventricle will be capable to pump out the blood into the aorta and cause the systolic phase over here. And definitely at the systolic phase, the pressure in the ventricle will equal to the aorta. So you will see the matching of the curve of the left ventricular pressure and the aortic pressure over here. And after the LV pressure or RV pressure is less than the pressure in the aorta, the aortic valve will close here, and after the aortic valve close, that means at this phase we'll go to the isovolumetric relaxation time, right? That means all valves are closed again, and the pressure in the ventricle will try to reduce the pressure inside the chamber because because it need to prepare themselves to get the blood from the atriums again, just like to try to create the less pressure to get, I mean about that, to make the pressure in the ventricle lesser than the atrium in order to get the blood from the atrium by the different gradients. Okay, and interestingly, that at this point, after the aortic valve close, you will see about the bump over here. The bump here refer to the aortic valve close because of the, let's say, about the compliance of the aorta, which is a property of the aorta that will after the left ventricle can pump out the blood into the aorta will dilate a bit, just like to make it more compliant, you know. Okay, after that, after the valve close, there will be some blood go back into the valve and cause the valve close. And then after that, let's say about the rebound of the blood flow, go to the aortic valve and then go forward again. So that why this bump is caused by the aortic valve close. Okay. So at this point, after the ventricle can reduce the pressure inside the chamber and lesser than the atrium, it will cause the aortic valve to, not aortic valve, it will cause the mitral valve or tricuspid valve to open again to get the blood from the atrium and go like go through this cycle again and again. And okay, anybody have any questions about this one? Okay, let's do next. Before we are going to be able to collect the correct hemodynamic information or data from recording in the cath lab, you're gonna have to make sure that you can set up the hemodynamic recording correctly. In the cath lab, you will have an equipment to just like to collect the data to just which is called pressure transducers. The picture showing you on the screen, I want you to just like to acquaintance about the different shape and form of the pressure transducer that you can be able to see in the real lab in the future. So these are pressure transducers. They look different, right? But they do the same function because the pressure transducer will convert the energy from the pressure inside the heart, convert that energy into the signal to show you on the screen that you can monitor during the case. Okay. How to set up the pressure transducer correctly? Definitely, you're gonna have to focus on this three-way. I'm gonna call this one as searing stopcock. Okay, you're gonna have to make sure that the searing stopcock here is at the level of the phlebostatic axis, which is at the mid chest. But actually, if you're not sure about where is the mid chest on the patient body, you just find the anterior axillary line, and then that level you can label as the mid chest, and you just try to place the pressure transducer and make sure that the zeroing stopcock is at the mid chest or at in the level of anterior axillary line. We actually call this axis as phlebostatic axis. Okay, just like this picture. If the problem is if you place this transducer or zeroing stopcock higher or lower than the actual level, you definitely, if you do that, you will get the wrong data during monitoring about the hemodynamic or the pressure inside the heart. Let's say if the pressure transducer is placed higher than the actual, I mean about the phlebostatic level at every 10 centimeters, the pressure that you can detect will reduce about 7.4 millimeters of mercury. Okay. I'm sorry, I'm wrong. I mean about if you place the pressure transducer higher than the actual level, definitely you will get the higher pressure that you can detect. Okay, and definitely every 10 centimeter higher than the actual level, you will the pressure will increase about 7.4 millimeters of mercury. But if you place the pressure transducer lower than the actual level, definitely you will get the lower pressure than the correct pressure that you could get. Okay. Let's say about the left heart catheterization. Well, um, why a doctor is doing, is going to do coronary angiography, we can say that the doctor is doing left catheterization because the doctor will insert the catheters inside the artery and go to which is a part of the left side heart. Okay, and the doctor will use a catheter in order to engage the ostium of the coronary artery in order to do coronary angiography, right? During the doctor do to engage the coronary ostium, you're gonna have to monitor to do I mean to uh to, to do monitor seriously because you're gonna have to be able to detect about the pressure changing all the time, and the pressure in the aorta will show you like this. This is the characteristic of the aortic pressure that you're gonna have to see about the systolic phase over here and the bump, a little bump here, which means about the which is called dichrotic notch, right? And this this one is referring you about the aortic valve close, right? And this at this phase means about the diastolic phase. So during the cast, you will definitely be able to see this aortic pressure all the time. So importantly, you're gonna have to be focusing on the hemodynamic screen because during the physician is trying to engage the ostium of the coronary artery. The, anything can happen to the pressure. About the damping pressure that I'm gonna tell you again in the in the last time. Okay. Well, this characteristic of pressure of aortic arch and femoral artery, I want you to know about the difference of the pressure from the central pressure and the peripheral pressure. You will see the difference here. Look at the arrow here from both sides. You will see that the the arrow is trying to identify you that about the dichrotic notch, right? So you will see that the 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 pump or the dichrotic notch at the aortic arch will be quite close to the systolic here, right? Because the pressure the pressure is detected in the aortic arch is close to the aortic valve, so the dichrotic notch is close to the systolic. That is the that is the basic characteristic of the aortic arch or aortic pressure. But when we see at the femoral artery, you will see that the dichrotic notch will a bit more, not like this, a bit more wider and smoother, something like that. And definitely it's quite later than the dichrotic notch at the aortic pressure, right? Because the distance, about the long distance from the aortic valve, into to the femoral artery, that is quite long distance. So that's why the peripheral art, let's say about the peripheral pressure from the artery will look like this. Okay, after you know about the aortic pressure, then I'm gonna go to the left ventricular approach by inserting the catheter and then to try to approach the LV into the LV. The pressure in the LV will be detected, and you see the pressure characteristic like this. As I said earlier, that the systolic pressure of the LV will be equal to the aortic pressure, right? This is called the systolic phase. Okay, and after systole, this is the phase of the diastole. The pressure due to the pressure in the left ventricle will try to reduce the pressure itself inside the ventricle in order to 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 try to be able to get or to receive the blood from the lower pressure in the aorta. The lower pressure in the atriums. So that why the diastolic pressure of the LV is quite low, almost close to the scale over here. And the importance of the LV pressure is the doctor wanna know about the LV EDP or left ventricular end-diastolic pressure, which is here. This is the LV EDP. But actually, at this LV EDP will align to the R wave, because the LV EDP is the end of the diastolic phase, right? Before the left ventricle will pump out the blood and cause the sharp upslope here, and then pump out the blood into the aorta at this phase, and then go down again like the sharp downslope here, because at this phase we'll go back to the isoverometric relaxation time, and then go into the diastole. About the ventricular filling and the atrial kick at the final of the diastole. something like that. Oh, well, in the lab, if you see the LV pressure, maybe the doctor not doesn't intend to approach the LV intentionally or by intention or something like that. After you can see about the LV, you're gonna have to notify the doctor that okay, LV pressure is showing you on the screen or something like that. The doctor may ask you to measure the LV EDP. So you're gonna have to change the scale from the maximum, but actually the scale, the original scale for monitoring the left side heart will be around 200 millimeters scale. Okay, after you seeing about the LV pressure and the doctor asks you to measure the LV EDP, you're gonna have to change the scale into around 50 millimeter scale in order to be able to see clearly about the LV EDP. Just like that, you can see the red line here. As I said you before that the end, the actual pressure of the LV will align with the R wave over here. Okay, this is the end actual pressure of the LV. This is normal pressure ranges. You can, but actually I just want to show you, but for my class I'm not serious about that. You will be able to memorize or remember all of these normal pressure ranges. But when you are doing a test, that is another condition. I'm not sure that in the test you will be able to see this kind of normal pressure ranges because I'm I'm not serious about this normal pressure because it depends on each books or each textbook that you can find to see because they are quite a bit, let's say about a bit or quite different about the normal values. So if you wanna memorize the normal pressure ranges, you just try to memorize the easy value just like that 110 to 130 or something like that. But the purpose of me that I want you to be able to tell the doctor about the doctor's requirement. For example, if you're gonna have to tell the doctor about the aortic pressure, you're gonna have to say systolic over diastolic, right? But if you're gonna have to notify the doctor or tell the information or the data about the LV pressure, definitely you're gonna have to tell him just about the LV EDP, just only the LV EDP. That's it. Okay, this is the example. Well, Okay. After you all know about the aortic pressure and the LV pressure, definitely the LV pressure, the doctor may use the pigtail to approach the LV because not want the LV to damage or to injure the left muscle inside the left ventricle or something like that. So the pigtail will be used to approach the left ventricle. In this case, the doctor used the pigtail to approach the LV because they want to do LV angiography by using this machine. This machine is called injector, syringe injector, that can create more pressure to win the pressure inside the LV because because we need to set up the pressure for the injector around 300 millimeter, which means that is very higher than the LV in order to try to inject the contrast inside the syringe injector over here and then to make it spread throughout the LV, just like this image. And the benefit of doing LV angiography is that you can find the LV, the EDV and ESV. EDV means end-diastolic volume, and ESV stand for end systolic volume. If you can find EDV and ESV, and after that you take off this value into this equation, you will be able to get the ejection fraction from doing LV angiography. After the catheter, which is placed, which is placed inside the LV, if the doctor pull back by pull the catheter, pull that catheter, and then back into the aorta, the information that you will see from this pressure changing is that about the gradient across the aortic valve. As I said earlier, that if the patient has no any sign of a stenotic aortic valve disease, the systolic pressure of the LV should equal to the systolic pressure of the aorta, right? But if a patient has a stenotic valve of the aortic valve, after pull back the catheter from the LV into the aorta, you see a little difference of here between the systolic of the LV and the systolic of the aorta. That means the pressure is showing you about the gradient across the aortic valve properly, that the patient has a stenotic aortic valve. Okay, after we have done all of the thing inside the left heart catheterization, after that we are going to the right heart catheterization. how to do that, but actually the doctor gonna use a special catheter insert through the femoral vein and then to approach the right side of the heart to the right atrium, and then the doctor can advance that catheter from the right atrium into the right ventricle and then into the pulmonary artery, something like that. That special catheter is called a Swan-Ganz catheter, which has 3 ports like this, and definitely at the end of the tip of the catheter will have the balloon at the tip of the catheter in order to use it to get the pressure, which is called pulmonary capillary wedge pressure. I'm gonna tell you again later, okay? This picture I just want to show you about the the structure and the shape of the Swan-Ganz catheter. At the tip, okay, let's see. At the tip of the catheter, you will see about the distal lumen opening over here, and this is the part of that. This is a part of the balloon that can be inflated to be able to monitor about the pulmonary capillary wedge pressure, and here this is the Thermistor Lumen opening. It is beneficial for recording about the changing of the temperature of the blood temperature that we are going to talk about this one again in the cardiac output finding of the thermal dilution technique. Okay. Okay, and the last one, I'm gonna want you to know more about this one. The proximal level opening is over here. Okay, so from the full port over here, you will see about the Thermistor Lumen port, proximal lumen port, distal lumen port, and this one is the inflation lumen port of the balloon, right? So the Thermistor Lumen port will be over here, right? And the proximal lumen port, this port will showing you here, and the distal lumen port will show you over here. Okay, the balloon port will be here. Okay, look at this picture. About the picture here is showing you about the doctor just like to insert the Swan-Ganz from the superior vena cava, and then the catheter is going down from the SVZ into the RA into the RV. After that, go to the pulmonary artery, and then go to the branch of the pulmonary artery. If you wanna get the pulmonary capillary wedge pressure, you as I told you before that you're gonna have to blow up the balloon at the end of the catheter. You're gonna have to make sure that the balloon is totally occlude that branch in order to be able to only detect the pressure from the distal port over here, and the pressure you can detect from here will be the pulmonary capillary wedge pressure, and this pressure will be equal to the LA pressure. We use this one because we don't want to we try to measure the pulmonary capillary wedge pressure in order to we don't want to do interatrial puncture to approach the left to approach the left atrium. Okay, so just like we can estimate the LA pressure from doing this if the patient has no any lung diseases. Okay. The different chambers, definitely the different characteristic pressure waveform. In the right atrial pressure will show you the waveform like this, that there are AZX revive. Okay, I'm gonna tell you about the detail about the AZXVY again. And after the catheter go into the right ventricle, the pressure will show you like this, but actually the pressure waveform of the right ventricle will look like the pressure from the left ventricle, but a bit different about the pressure because the right side of the heart, the pressure from the right side of the heart is very lower than the left side of the heart. Okay, and after the cardiac catheter go to the pulmonary artery, the pressure will show you look similar to the aortic pressure, but lower. But the pressure is lower than the aortic pressure, definitely. Okay, after that, the doctor will advance the catheter, go advance the catheter, go to the pulmonary branch over here, and then try to blow up the balloon at the end of the catheter, and the pressure you will get will be like this. You will see that the pressure of the pulmonary capillary wedge pressure looks quite similar to the right atrial pressure, because the pulmonary capillary wedge pressure we can do this pressure represent of the LA pressure. Okay. Okay, the normal pressure ranges can show you like this. Well, let's take a look at the pressure inside the atrium. You will see about a lot of wave here. There are A wave, C wave, V wave, and what about the X and Y? The X, we call this as X descent, and Y we call this one as Y descent. Okay. Let's get started with the A wave. After the atrial contraction, definitely the atrial contraction will cause the about the high pressure inside the atrium, right? So it causes the A wave over here, After that, after the volume and the pressure inside the atrium from the atrial kick, after that the pressure will gradually decrease and then go to the tricuspid valve will close over here at the end of the artery, right? Okay, just remember, if you have the pressure waveform here, and then you have the EKG, you're gonna have to keep in your mind that at the peak of the R wave is the end of the diastole. So if I create a line over here, this point will be the point at the tricuspid or mitral valve are closed, right? After that, we'll go to the systolic phase over here until the end of the T wave over here. Okay, at this one, why is the C wave on the pressure of this pressure where it comes from? Let's say about that inside the left ventricle or in the right ventricle. Inside the ventricle, after the mitral valve or tricuspid valve closed, that means the pressure inside the ventricle is equal to the atrium, right? After that, the ventricle will try itself to create or to build up more pressure. So the pressure inside the ventricle will just like to push back the blood, slam the let's say about slam the tricuspid valve or mitral valve, and the pressure in the atrium will a bit increase because of the tricuspid, because of, let's say about this sentence, the question about elevation into the right atrium because of the LV pressure during the pressure in the LV is increasing. Okay, let's say that. And after that, after the LV pressure after the pressure in the ventricle increase for a while, then the blood inside the ventricle will be injected into the aorta or into the pulmonary artery. So the less volume, that means the pressure will be lesser. So that will show you about the X descent over here. After that, after the end of the T wave, all of the valve will close again. All of the valve will close again, right? Okay, at this point, you imagine after the blood from the left ventricle is ejected into the aorta, the blood will go through the systemic circulation, right? And after that, okay, go to the systemic or pulmonary circulation or something like that. If depends on the which chamber you are focusing on. I mean both RV or LV. If the LV contract or pump out the blood into the aorta will cause the systemic circulation, right? But if the RV pump out the blood into the pulmonary artery, it will cause the pulmonary circulation. So after the ventricle pump out the blood, all the blood out of the ventricle at this phase, all of the valve close, and then this is the period. This is a period of the diastole of the diastole. That means there is some blood from the systemic or pulmonary system go back to the heart, to the atrium. So that's why the atrium has the increased pressure over here. Okay. And then after that, we'll go to the wide descent. That means the tricuspid valve opens in early ventricular diastole, so the pressure will gradually slow down. Okay. This is the information that you can read by yourself from this. Okay. This is a table that I want you to show more about the normal values ranges from each chamber over here. I think this normal value is quite memorizable, so easy to remember. So if you want to memorize the normal values of each chamber, you can memorize just like this. But because it will help you, definitely it will help you to be able to diagnose more easily when you work as a monitor in a laboratory to see the different or the abnormal pressure in the real time. Okay. Again, the typically reported, you're gonna have, but definitely you're gonna have to know that which chamber should, which chamber and which value should be reported to the doctor. Let's say the aortic pressure, you're gonna have to report as systolic over the diastolic. The same pulmonary artery pressure, you're gonna have to report as systolic over the diastolic. What about the pressure inside the atrium? Because the atrial pressure will have A wave, B wave, and C wave or something like that. So which value should you report the doctor? Definitely it should be mean value. So mean value will be reported for the pulmonary capillary pressure or LA pressure and the RA pressure as the same. Okay, the two last one, the left ventricular, about the ventricular pressure will be reported as EDP. Okay, just memorize. Okay, you're gonna have to be able to memorize after this. All of this kind of reported value. Okay, this diagram or this graph is showing you about the normal oxygen saturation and pressure ranges again in the heart chambers and great vessels. Definitely, the right side of the heart should have the lesser oxygen saturation than the left side of the heart as normally. Okay. Okay. Next, I'm gonna I'm gonna talk about the formulas and calculations. The outlines you will be able to learn about the cardiac output calculation, systemic and pulmonic vascular resistance calculation, and the shunt calculation. Okay, before continuing, anybody has any question about what I have described you before? Okay, well done. Okay, next. When you do the right and left side, when you do left or right side heart catheterization, you're gonna have to be able to calculate the cardiac output. Let's say about the common equations is from the fixed method that you will be able to use this method to find or to calculate the output. So the cardiac output will equal the oxygen consumption divided by arterial mixed venous oxygen difference and then multiplied with 10. And so how can we find the oxygen consumption? Definitely we can use this value to find the oxygen consumption. If you have if you have the patient's weight, you can use 3 to multiply with let's say about to multiply with the patient's weight. But if you have the information about the patients, just like the BSA, you just use the BSA to be multiplied with 125. That's it. And what about the oxygen content? The oxygen content, you can use this equation, oxygen content equal saturation, percent saturation, multiply with 1.36, and then multiply with hemoglobin. So in this equation, you're gonna have to remember that if you wanna use the fixed method to find or to calculate the cardiac output, you're gonna have to have percent oxygen saturation and hemoglobin. Keep in your mind, okay, about this equation. You're gonna have to remember that you require two things from the lab, that percent oxygen saturation and hemoglobin. Okay. For example, if the arterial saturation is 95%, PA saturation is 65%, hemoglobin is 13 gram per deciliter, and the patient weighs 70 kilograms, cardiac output will be determined as follows. So we know that the equation for oxygen consumption is we got weight from the patient's weight from the information, right? 70 kilogram. Okay, we got the weight. So we need the value, the constant 3 to multiply with the 70, and then you will get the oxygen consumption as 210 milliliter per minute. Okay, after that, let's go to find the cardiac output. So the cardiac output will equal 210 and then divided by arterial mixed venous. So you need to change the percent into the flow numbers just like this. Okay, it will be an arterial mixed venous. So 95% will be 0.95 here, and then minus with the saturation in the PA, which is 65%, will be 0.65, and then multiply with 1.36, then multiply with 13 from the hemoglobin, okay, and then multiply with again with 10. After that, you will get the final cardiac output, which is 3.96 lit per minute. Okay, again, keep in your mind, if you want to calculate the cardiac output, you need percent oxygen saturation from the artery and the percent oxygen saturation from the pulmonary artery, because you're gonna have to find the arterial mixed venous oxygen saturation, right? Just like this equation. And the last one, you're gonna have to get from the information is that hemoglobin. Okay, there are two things you're gonna have to keep in your mind that you need to find to calculate the cardiac output. Yeah. Okay. The previous one is the cardiac output that is calculated by the fixed method that you can get the oxygen saturation or the hemoglobin from doing blood gas inside the lab. Okay. Another cardiac output calculation is the thermal dilution technique. Definitely, the doctor will use the swan gangs again in order to advance the catheter, this catheter inside the right side of the heart by place the just let's say by place the tip of the catheter inside the branch of the pulmonary artery like this, without blowing up the balloon at the end of the catheter. So the doctor will make sure that the proximal port on the catheter is inside the right atrium, and the distal port of I mean about the distal lumen on the catheter is at the end of the catheter, is inside the pulmonary artery or something like that. But the doctor gonna have to make sure that the proximal port is inside the right atrium. So the doctor will use the 5 cc syringe to inject the cold injectant solution inside through the proximal port. So the cold injectant will get inside, will go into the right atrium over here, and then the injectant will mix with the blood. I'm sorry, I'm wrong. Okay, again, the proximal port will be just like at the over here, in the right ventricle. Okay, the proximal port will be placed in the right ventricle, and the distal port will be in the pulmonary artery over here. After the doctor inject the cold injectant over here, the the solution will get out of the catheter and go into the right ventricle. After that, the blood inside the right ventricle will mix the blood with the cold injectant and change to be the cold blood. After that, the cold blood will flow through the pulmonary valve and then go to the pulmonary artery. The, the cold blood will be detected at almost the end of the catheter to detect about the changing of the temperature from the proximal to until the end of the catheter. So the computer will be able to detect about the time and the temperature that has changed during the time of the cold blood inside the right ventricle here travel to the pulmonary artery until the thermistor at the end of the catheter here. It will plot the graph like this, and then the computer will find the area under the curve over here, and then you will get the cardiac output, the value of the cardiac output. Definitely the doctor will do this around 3 or 5 times in order to get the average values of the cardiac output to get the most reasonable cardiac output or correct cardiac output. Okay. The disadvantage of this of the thermodynamic technique is that if you cannot, the doctor cannot do this technique in the patient who has tricuspid regurgitation and the patient who has the poor cardiac output. I mean about the LV function. LV function is not good, something like that. And the last thing is that the the patient has no arrhythmia because the arrhythmia will cause the variable, I mean the unreasonable cardiac output from calculating by this technique. Okay, let's see about the tricuspid regurgitation. Why the TR will cannot. I mean about the tricuspid regurgitation patient cannot use this technique because after you inject the cold injectant solution inside the RV, if the patient has TR, definitely the blood cannot only go through the pulmonary valve after RV pumping out the blood out to the pulmonary artery, but there is some blood going back into the right atrium. So if we do the thermal dilution technique in the tricuspid regurgitation patients, definitely the final cardiac output will not accurate anymore because of the blood flowing back into the right atrium. Again, with the poor RV, that the heart cannot pump out effectively. So definitely the blood that will be pumped out to the pulmonary artery from the ventricle will go through the pulmonary valve, and then the blood will flow very smoothly or something like that. The curve the time of the injectant of the cold injectant solution from the RV here, the time to it quite take time to go to the thermistor at the end of the catheter. So you will see about the time over here and the blue line here. The time will quite long over here. Okay, it quite take time in the poor cardiac output. Okay. The information from doing right heart catheterization and left heart catheterization, you can use all some of the information there to calculate the systemic vascular resistance and pulmonary vascular resistance. Let's say, okay, let's take a look at the systemic vascular resistance. The abbreviation of the systemic vascular resistance is SVR. Okay, so SVR equal mean arterial pressure minus pulmonary artery pressure and then divided by cardiac output. Just imagine to make you more understand more easily. If you look at the systemic vascular resistance, or let's say you are focusing on the systemic circulation, right? The systemic circulation is started from the LV. I mean about the LV, the left ventricle pump out the blood into the aorta, right? That is the starting point. And the end of the systemic circulation is that at the pulmonary artery, because after the pulmonary artery the blood from the pulmonary artery will go to the lung, right? So we can make this pressure of the pulmonary artery as the end of the systemic circulation. So we can have the starting point and the end point of the systemic circulation. We can use that pressure inside the arterial pressure and the pulmonary artery pressure and find the difference value of this and then take it to divide by the cardiac output. You will finally get this SVR value. Again, with pulmonary vascular resistance, I'm sorry, my slide is a bit wrong. Okay, it should be MAP minus RAP. I'm sorry for that. I'm sorry for the wrong thing happening. Okay, MAP. So, but actually the the starting point of the system. Okay, the starting point of the systemic vascular systemic circulation will start from the aorta, right? And then we'll finish at the RA. So it could be MAP minus RAP and then divided by the cardiac output. Let's say about, the same thing as the pulmonary vascular resistance. The PVR starting point of the pulmonary circulation start from pulmonary artery, and then finish at the LA, right? The LA mean the pressure in the LA, but we can find the LA without approaching directly to the left atrium. So we can use the pulmonary capillary wedge pressure instead. So it will be PA, pulmonary artery pressure, minus pulmonary capillary wedge pressure, and then divided by cardiac output. Okay. The unit of SVR and PVR would be Wood units. If you want to change the unit of the SVR, you can multiply with 80 in order to change to be this unit. Okay, this is the calculation summary and normal parameter ranges. You can come to review about the formula over here and about the normal range. This is the data interpretation summary. You can, but I just want to show you, just only show you, but if you want to do a more understand, you can, yeah, you can come back to review about the abnormal intracardiac pressure and the abnormal pulmonary vascular resistance or systemic vascular resistance, and try to think about if this happen, it will cause some condition, which condition will cause to the patient or something like that. For example, if the patient has high CVP, low cardiac index, and high PVR, yeah, let's say the doctor can maybe consider that the patient has right heart failure or something like that. Well, we can calculate more about to find the shunt. From this slide, I'm gonna show you about a simplified formula to find the ratio QP to QS. This formula, just like yeah, you can following this formula, the saturation of the aortic pressure, the saturation in the aorta will minus the saturation in the mixed venous, and then take off this to be divided by the saturation in the pulmonary vein in the pulmonary vein, and then minus with saturation in the pulmonary artery. But the saturation of mixed venous, you can find this value from this equation. Okay, you may have a question that, and what about the pulmonary vein? How can you get the oxygen saturation from the pulmonary vein? Because as the doctor do not approach the catheter inside the pulmonary vein for sure, right? But in the real lab, the doctor will use the oxygen the oxygen saturation from the aorta or the alveoli, yeah, just like the oxygen from the left side heart, because he will we can consume that the pulmonary vein take the blood from the lung into the left atrium, and then travel that blood into the left ventricle, and finally go to the aorta. So that's why the doctor we can assume the oxygen saturation of the pulmonary vein that is equal to the saturation of the aorta. And all the other saturation we can get from the lab, yeah, definitely the saturation in the SVC and in the IVC, the doctor will get the blood from that site and then go to go to the blood gas test, and you will be able to get the information from that. After calculate the shunt, if the ratio of the QP to QS less than 1.5, we can consider that the patient has a small left to right shunt. If the QP to QS between 1.5 and 2.0 that are obviously intermediate in magnitude, so the surgical intervention is generally recommended if the operation risk is low. And the last one, if the ratio is less than 1, indicates that the patient has right to left shunt, and definitely it presents irreversible pulmonary vascular disease. That means the flow, about the blood flow go to the pulmonary more than go to the systemic circulation. Just think of the from the equation, the ratio, the QP. If the QP less than QS, the flow go to the pulmonary is lesser. That means the volume from the right side of the heart, the volume from the right side of the heart is go to the lung, or is go to the lung lesser than the blood from the left ventricle go to the systemic circulation, because of there is amount of blood from the right side of the heart go to the left side of the heart. The thing can make this happen is that the right side of the heart must have the higher pressure more than the left side of the heart. Okay, because actually, if that is some if that is ASD or VSD, then imagine the left side of the heart is more, it has more pressure, right? Higher pressure than the right side of the heart. But if the patient has no any operation or do anything before the pulmonary before the patient get the pulmonary hypertension, that means it will cause the right side of the heart more higher pressure than the pressure in the left side of the heart, that will cause the right side of the heart can, let's say, pump out, or the blood can go to the left side of the heart by the difference of the grade the pressure, the different pressure from the higher pressure from of the right side of the heart than the left side. Here is hemo condition page that this is an example of from the Philips model that you may be see in the future when you working in a laboratory with the environment of the Philips system, you can feel the saturation that you get from blood gas, and then fill in this box and in each chamber, and you can change. If you want to add more about the pressure, you can click at the tab of the pressure, and then you can feel the pressure in each side of the site. Okay, if you can complete and feel all of the significant or of the important value, definitely the system will calculate the output, maybe by definitely by fixed methods that you can, if you can feel the oxygen saturation from each chamber or each site, and then you feel the hemoglobin. Of course, finally, the system will calculate the cardiac output for you. Okay, finish just the first half part of the topic. Anybody have any question before we take a break for 10 minutes?
I have a question ค่ะ
ครับผม
It is on the slide number 41 ค่ะ
41
So 41 is about early under the curve. Or in the 40 ค่ะ
and 40.
Oh, yes, this one. I want to know that area under the curve between tricuspid regurgitation or poor cardiac output, comparing with the normal values, it is decreased or increased the area under the curve.
Oh, okay. Let's see about the tricuspid regurgitation first. The let's maybe about the purpose why. The purpose why here, you're gonna have let think about the blood flow. Definitely, the peak of the curve will definitely not equal to the normal cardiac output because of the blood, the mixed blood with the cold injectant solution will have some mixed blood get into the right atrium, right? So the whole blood that should be expected to go to the the tip of the catheter will be not the whole blood, right? So yeah, we can say that the peak, the different peak of the curve will not the same, definitely. But what about the time? Let's say maybe because of the, I'm not sure about this time, because if in the normal cardiac output, but the patient has the tricuspid regurgitation, definitely the some mixed volume will about to share the blood. Let's say about that, because after right ventricle contraction, the blood will go back to the right atrium, right, and some blood go to the pulmonary artery. So the rest of the blood that go through the pulmonary valve and go to the pulmonary artery until the mixed blood into the thermistor at the end of the catheter maybe quite take time, a bit more take time until that But about the poor cardiac output, let's say the poor cardiac output or RV function is it's not that good functional. The whole blood still go through the pulmonary artery and then go to the tip of the catheter. The whole blood still the same amount of the blood, right? But it quite takes time to go to at the end of the catheter because of the poor RV function, something like that.
I got it ค่ะ thank you so much ค่ะอาจารย์
อันนี้เข้าใจใช่ไหมครับไม่มั่นใจเหมือนกันอันนี้ตอบโจทย์ไหมอ่ะ
เข้าใจค่ะแต่หนูขออีกคำถามหนึงเลยค่ะหนูสงสัยว่าแล้วอย่างไอ้ normal cardiac output อะค่ะ
ครับ
หนูจำได้ว่าเคยอ่านเลคเชอร์หนึ่งเขาบอกว่าพวก cardiac output กับ cyclic recurrent area under the curve มันจะน้อยกว่าหรอคะเฮ้ยดูรูปแล้วมันงงว่ามันน้อยกว่ายังไง
อ๋อคือมันคือถ้าอย่าง tricuspid valve อันนี้พูดภาษาไทยได้ไหมวะ น่าจะได้เนาะแล้วถ้าเกิดว่า tricuspid valve regurgitation เนี่ยคือว่ามัน area under the curve เนี่ยมันถ้าขยายจริงๆคือพูดยากตรงที่ว่าคือมันจะไม่ accurate แล้วกันคือจะบอกว่ามันน้อยกว่ามันถ้าคำนวณแล้วอ่ะพี่ถ้ามันตามสูตรเนี้ยพี่ก็ถ้าตามรูปนี้นะคุยกันดีวะจริงๆแล้วมันตามทฤษฎีเนี่ยมันน้อยกว่าแล้วตามจริงๆถ้าทำจริงๆอ่ะก็น่าจะน้อยกว่าเพราะว่าไอ้ตัวพีคตรงเนี้ยพี่ว่ารูปเนี้ยอาจจะไม่ได้ accurate มากไม่ได้หมายว่าไม่ได้100%ที่ว่ามันจะถูกขนาดนั้นแต่ว่าถ้าตามทฤษฎีแล้วเนี่ยเลือดอ่ะมันไม่ได้สามารถเอาไปได้หมดถูกไหมครับมันไหลเข้าไปใน RA ด้วยส่วนหนึ่งอะไรเงี้ย แต่เรื่องของการ take time เนี่ยพี่คิดว่ามันน่าจะเป็นกรณีที่เลือดมันไปน้อยอ่ะมันเหมือนกับมันเหมือนกับมึงจะบีบตัวได้ดีอ่ะแต่เลือดกว่าที่เป็น mix blood อะครับกว่าจะออกไปแล้วไปจนถึงปลายนู้นนะมันก็จางหมดแล้วครับคือความเข้มข้นของความเย็นของ injectant ที่มันฉีดไปอ่ะมันมันมันแบ่งส่วนหนึ่งออกไปเข้า RA แล้วมันแบ่งอีกส่วนหนึ่งของมันใน PA อ่ะ มันไม่ได้ไปด้วยความเข้มข้นเดียวกันที่มันควรจะออกไปถึงที่ปลายของแคทเตอร์ครับแน่นอนว่าไอ้ส่วนของ timing อ่ะมันก็อาจจะทำให้มัน detect ได้ว่าอ๋อเนี่ย temperature change จนมาถึงตัวมันเองเนี่ยก็จนกว่าแบบ blood เนี่ยกลับมาถูที่ temperature เดิมอะครับไม่ถึงอุณหภูมิเดิมอะมันก็เลยค่อนข้างแบบอ๋อเนี่ยมันนานไปหน่อยนึงนะอะไรประมาณนี้ครับเพราะเลือดมันกระจายตัวเลือดที่มันมิกซ์มันกระจายออกไปหมดแล้วแล้วก็ส่วนพวก cardiac output อ่ะมันอาจจะได้ area curve ที่มันกว้างกว่าเพราะเนื่องจากว่า time มัน takes แต่ว่าตอนที่เราอ่านนะครับอันนั้นน่ะเราบอกว่าpoor output เนี่ยมันได้น้อยกว่าจริงๆใช่ไหม
ใช่ค่ะ
อืมเอ่อถ้างั้นเดี๋ยวพี่ไปศึกษาเพิ่มเติมแล้วกันตรงเนี้ยแล้วเดี๋ยวพี่มาตอบอีกทีได้ไหมครับเดี๋ยวพี่หาคำตอบให้
ได้ค่ะขอบคุณมากเลยค่ะ
ได้ครับแต่ว่าเอาเป็นว่าจำ imaging ถ้าสมมติว่าไปสอบอย่างเงี้ยเอาเป็นว่าไอ้ poor cardiac output กับ tricuspid regurgitation เนี่ยเราจะไม่ทำแล้วกันเพราะว่ามันเอาแน่ๆไม่ถ้าสมมติตอนนี้มันยังคอนเฟิร์มไม่ได้ว่ามันมากกว่าน้อยกว่าอย่างเงี้ยคือมันได้ความ accurate ไม่ได้แน่ๆอยู่แล้วถูกปะคือมันความ accuracy ของมันค่าที่ได้ออกมามันไม่ถูกต้องอยู่แล้วมันก็เลยยังไงก็ห้ามทำในกลุ่มผู้ป่วยพวกนี้แล้วก็อีกอย่างหนึ่งคือพวกอาริทเมียครับผมเพราะมันจะได้เอาพุตไม่ได้ถูกต้องแน่นอนอันนั้นอาจจะน้อยกว่าหรือมากกว่าขึ้นอยู่กับว่าตอนนั้นเน่ะเป็นอาริทเมียประเภทไหนนะครับเดี๋ยวส่วนที่เหลือเดี๋ยวพี่ไปหาคำตอบมาให้นะขอโทษทีครับ
ขอบคุณค่ะ
Okay, anybody has other questions before going to take a break for 10 minutes?
ยังไม่มีค่ะ
โอเคได้ขอบคุณครับงั้น Okay, we will come to see again at around 11 o'clock. Okay?
ค่ะ
Okay, ครับงั้นก็ bye for now. See you in 10 minutes. Okay. Okay. Welcome back, and everybody here.
Yes ค่ะอาจารย์
โอเคครับ Okay. Okay. In the first half session, there was some error happening to me. I just want to describe you again about the pressure transducer setup. In the morning, I'm not sure I described you correctly, but I just want you to describe you about it again. Okay. The zero stop. I mean about the pressure transducer. Yeah, as I said earlier that the zeroing stopcock must be at the same level of the phagostatic axis or at the mid chest or at the level of anterior axillary line, right? If the pressure transducer is placed higher than the actual level, if it is placed higher at the body and the actual level, definitely will cause just like this. Okay, the pressure that you can detect will be lower than the actual pressure that you could get. Okay, if the pressure transducer placed lower than the body or than the phagostatic axis level, definitely it will cause the pressure you can detect is higher than the actual value. Okay, if the pressure transducer placed higher than the phagostatic level every 10 centimeter, it will cause the pressure low that you can detect lower than the actual value around 7.4 millimeter. Okay, just like this actual. Okay, because the pressure will depend on the gravity as well. If the pressure transducer is placed lower than the level, definitely it will measure the pressure will be measured as higher, just like the gravity will have an impact on this as well, or something like that. Okay, and the second point is that about this one. Okay, the proximal port that the cold injectant solution will be injected out. That side is in the right atrium, yeah, just like this, into the right atrium or something. Okay, over here, this is the proximal port that the cold injectant solution will get out into the right atrium over here, and then the top port is at the end of the catheter again. And after during the break, I searched I searched something about the poor cardiac output, the impact on the commodulation technique. After I reviewed that, I got the the answer that if we do the thermal dilution technique in the poor cardiac output, the result from doing this will cause an overestimation of the cardiac output because of the RV function is not good. So the blood that mixed with the cold injectant will slowly just like cannot be cleared out of the RV right ventricle as normally as the normal cardiac function. So that why the timing of the cold blood is quite long, just like the graph, the curve here. Okay, just like this. In a cardiac low cardiac state, blood is rewarmed by the walls of the cardiac chambers and surrounding tissue, resulting in overestimation of the cardiac output. Okay. อันนี้ตอบโจทย์ไหมครับยังไม่รู้เหมือนกันตอบโจทย์ไหม
ตอบแล้วค่ะขอบคุณค่ะอาจารย์
โอเคครับ Okay, well, let's go to the valvular stenosis. The stenotic valve, that means that there is something obstruct the valve or obstruct the way from the chamber to another chamber, right? So when we look at the stenosis of the aortic valve, let's see about the pressure has changed for each chamber, just like this. Let's think, before you think of a stenotic valve or regurgitation valve, you're gonna have to think of which chamber is preceding the valve and which chamber is following the valve. For example, in aortic stenosis, the preceding chamber is the LV chamber, right? It is preceding the valve. The following chamber is aortic valve. So if we can focus this, you can just focus the two sides or two chambers between the valve you are focusing on. For example, in the aortic stenosis, you can just the chamber with preceding the valve and the following the valve is the LV and the aortic valve. So definitely it will cause the pressure gradient between two chamber across the valve. And you're gonna have to think of which phase of the heart will be affected. The aortic valve stenosis definitely will be affected during the systole. That means the RVs, while the left ventricle is contracting to pump out the blood into the aorta. So if you can imagine like this, you will see that the LV pressure will try to, let's see, from the normal and aortic stenosis, right over here, you will see that from the normal, if the patient has a stenotic aortic valve, the LV pressure, the left ventricle will try to build up itself to be able to get more higher pressure to overcome the pressure in the aorta and the obstruction of the valve. So the left ventricle will try to compensate itself to just like to pump to build up the muscle to get more hypertrophy or something like that. So after the RV can create or can build the pressure more higher than the aorta or aortic valve, the LV, the left ventricle will be able to pump out the blood into the aorta. Let's imagine, but the aorta, there is nothing just like the disease in the aorta, but the disease is occurring at the aortic valve, right? So the pressure from the LV will try to overcome the aortic valve that is stenotic. And so after the pressure of the LV is equal to the pressure in the aorta, I mean about the pressure from the aortic valve that try to impede the blood flow from the LV into the aorta. The pressure in the volume into the blood flow that will go to the aorta will be reduced because of the obstruction of the AV of the aortic valve, right? So you will see that the left ventricle has very high pressure of the systolic, about 200, but in the aorta, because of the volume is reduced by the obstruction of the aortic valve stenosis, the pressure in the aorta will be a bit dropped due to the lesser volume, okay? And after that, the impact of the LV hypertrophy or the pressure gradient, the pressure in the LV will, due to the LV cannot pump out the pump all blood in the LV to overcome the aortic valve and into the aorta, there is some blood still back up in the left ventricle in the face of the diastole, so it will cause that the left atrium gonna have to build more pressure to build up more pressure in order to overcome the pressure in the left ventricular and the diastolic pressure to pump out the blood inside the LA into the LV. So the LA causes the LA more higher pressure than normal. You will see that from 10 to 25. Okay, look at the graph. Look at the graph, you will see that. Okay, just imagine when you look at the graph, you just gonna have to think of which, let's say, which phase you are gonna have to focusing on. If you're looking at the aortic valve and the patient has a stenotic valve, the abnormal pressure should be appearing on the face of systole, right? So you're gonna have to focus on the systolic phase over here. You will be able to see the aortic pressure and the left ventricular pressure. You will see about the gradients between these two pressures over here. That means that patient has a stenotic aortic valve, and you can calculate but actually the computer can calculate the aortic valve, I mean about the mean pressure gradient, they're under the curve over here in the gray zone over here. Okay. Well, during doing left catheterization laboratory, we have two ways to get the gradient, I mean the different gradient of the LV and the aortic pressure. The first way is that just pull back pressure waveform from LV to aorta with one catheter. Okay. Starting with the LV pressure, that means the catheter is advanced into the left ventricle. After that, the doctor will pull back the catheter into the aorta, and you will see the difference of the gradient. Here is a peak gradient, right? And the peak gradient here, you can assume or you can calculate easily with the peak to peak gradient over here by take this peak systolic of the LV systolic pressure minus peak systolic pressure of the aortic pressure over here. Another way to get the gradient across the aortic valve is that a simultaneous pressure monitoring. That means the doctor gonna have to use two pressure transducers. You're gonna have to set up two pressure domes, right? The first dome is for monitoring the LV pressure from the catheter inside the left ventricle. The another dome, we will use it to monitor the femoral artery from the arterial pressure from the femoral artery by connecting to the femoral sheath. If the doctor will use this technique, the doctor will often use the French side of the sheath is a bit bigger than the catheter inside the LV. For example, if the doctor use a diagnostic catheter of 6 French to get the hemodynamic data from the LV, the sheath should be bigger size. For example, 7 French, because the doctor need to avoid the obstruction of between the same French side of the sheath and the catheter. Okay, so this is called the simultaneous pressure gradient across aortic valve monitoring. You will be able to get the LV pressure and the aortic pressure at the same time. But actually it's quite more accurate than the pullback pressure waveform, because you will be able to get the peak-to-peak systolic pressure from the left ventricular pressure and aortic pressure at the same time. And then you can find the mean pressure from calculating the area under the curve over here. Okay. let's say about the pulmonary valve. Yeah, but actually it is as same as I talked about the the gradients about across the aortic valve, just like you change the label of the pressure from LV into RV and aortic AO or aorta into the pulmonary artery or PA. The same idea that you're gonna have to focusing that which valve you are focusing on, definitely pulmonary valve and stenosis or regurgitation. So this one is stenosis. You're gonna have to think that if you wanna see about the difference between between the two pressure chambers, which phase you will see. Definitely for pulmonary valve stenosis, you will be able to see the different or the gradients during the systolic phase again. So you can just find the relationship between the EKG and the pressure over here, and then you see that after the R wave and until the T wave, you know that this is the systolic phase, and definitely you can find, and then you go to the pressure over here, and you will see that this is RV and this is pulmonary artery, so that is gradient of occurs over here. So yeah, that is describing you about the pulmonary valve stenosis, something like that. Okay. Next, mitral valve stenosis. Okay, again start with this picture, this normal and mitral stenosis. Okay. Oh, mitral valve stenosis, you're gonna have to think first that the chamber preceding the mitral valve and the chamber following the mitral valve. The chamber preceding the mitral valve is left atrium, right? And the chamber following the mitral valve is left ventricle. Okay, and then which phase of the cardiac cycle that will be affected? Definitely, it will be affected on the diastolic phase, right? Because the LV, the left ventricular, the left ventricle will be relaxing to receive the blood from the left atrium, right? That means that at this phase the mitral valve is open. Okay, the chamber preceding the mitral valve is our left atrium, so the left atrium will try to build more pressure to get higher than the left ventricle, because the left atrium must do that, because in order to overcome the the mitral valve stenosis that try to obstruct the blood flow from the left atrium into the left ventricle. So after the LA will be let's say will enlarge a bit and hypertrophy just a bit, and in order to create higher pressure. After that, the pressure during this phase, the diastolic phase, the blood from the LA will go to the left ventricle, but the volume, the blood cannot get out of the left atrium in order to go to the left ventricle because the obstruction of the mitral valve, right? So the LA will back up some blood, the rest of the blood that cannot pump out into the left ventricle. So the LA, it will cause the LA more higher pressure. You will see that from 10 to 25. At the same time, the volume cannot, the blood, I mean about the blood volume cannot pump out of the left atrium into the left ventricle. So it will cause the left ventricular volume during the diastole lesser. I mean, the mitral valve will reduce the volume in the LV in the left ventricle during the diastole. So the left ventricular in the diastole, that means about the volume will lesser. So the pressure is lesser than normal, from 10 to 6, just like this. Okay, and from let me refer to the Frank's starting rule. If the LV, if the volume in the ventricle is reduced, that means the let's say about the contract, it will impact on the capability of the LV function to contract the blood. If the blood is less than normal, the LV contraction will not as capable as to pump out the blood as normal. So you will see about the systolic pressure is a bit less than normal, from 120 to 115, just like that. And there is no any obstruction between the aortic valve over here, so the systolic valve will equal to the aortic pressure 115. Okay, this is an idea to describe about the mitral valve stenosis. Let's take a look at the graph over here. Okay, well, just imagine again, the mitral valve stenosis will impact on the diastolic phase, right? So you're gonna have to go to the diastolic over here. You already know that at this point of dichrotic notch means aortic valve is closed, right? And all of the valves are closed for a while because it is in the phase of isoverometric relaxation time. I mean about this point until this point. Okay, all of the valves are closed over here, and so it's telling you that this phase of the heart is in the diastolic phase. So you can just focus on this phase to see the gradient across the mitral valve stenosis that occur between the left atrial pressure and the left ventricular pressure over here, right? Okay. As I said earlier, the left atrial pressure will a bit more higher than the left ventricular pressure because of the mitral valve stenosis. Okay, for this tracing, you can just find the phase of the diastole first. Okay, you are the phase of the diastole will occur over here, right? Occur over here, and then finish at the R wave. So that is the difference of the gradient. There's a gradient occurs over here, and you can tell the doctor that there is mitral valve stenosis occurring for the patient by the pressure gradient that you can measure from the hemodynamic pressures monitoring. Okay. Next, on tricuspid valve stenosis, you can just the idea is the same as the mitral valve stenosis, but you can just change the label of the left ventricular pressure as RV, right ventricular pressure, and change the LA to be RA instead. And the same idea, you're gonna have to focus on during the diastolic gradient or the diastolic phase over here. You see about the gradient over here. Okay, this is the example of the tracing showing you about the tricuspid valve stenosis. Okay. After you can get all of information from doing right and left heart catheterization, you can calculate the valve area by using this equation, which is called Gaussian equation. The area equal valve flow divided by K, which is constant, which is constant, and multiplied with C, which is a constant as well, but it is an empirical constant. That means you're gonna have to change the value of the C depending on depending on the valve. Let's say that if there are if the valve that has 3 leaflets, we're gonna use the value, the constant of the value is 1. But for the mitral valve, which has 2 leaflets, right? The C will be 0.85 in the equation. Okay, the K constant is 44.3. Okay, and then multiply with square root of MVG mitral valve gradient. Okay, let's take a look at the real okay. The valve flow, where you can get the valve flow. The valve flow, you can calculate the valve flow following this equation. For mitral valve flow, you can just the cardiac output and then divided by the diastolic filling period and then multiply with heart rate, where the diastolic filling period equal the diastolic period and then multiply with heart rate. Okay, and for aortic valve flow, cardiac output divided by the systolic ejection period multiplied with heart rate. Let's take a look at for example. The data you obtained at the cath lab for aortic stenosis, the cardiac output equal 4 liters per minute. We can change into the milliliter as 4,000. Heart rate around 6 beats per minute. Mitral valve gradient is 58 millimeters of mercury, and systolic ejection phase is where is the SEP? You can see this from the systolic ejection period. Okay, as I told you before, this is the systolic ejection period. Okay, we measure in a centimeter, and SEP in this example is 4.1 centimeter, and then convert to time equal 4.1, and then multiply with 1 second and divided by 10 centimeter. It will be converted to be a value of 0.41 second. This number, maybe you have a question about how can I know about this number, but actually you're gonna have to go to the hemodynamic screen and then maybe capture the pressure over that. The scale, let's say about the scale, 10 centimeter on the hemodynamic screen is equal 1 second. So you can just try to find the use this one to try to find and exchange the unit to be a second by this. Okay, let's go to the equation. The flow equal cardiac output divided by systolic ejection period and then multiply with heart rate. So it would be cardiac output in milliliter per minute for 1,000 divided by SEP, that is 0.41 second, and then multiply with heart rate, which is around 60 beats per minute. And then the flow is 162.6 milliliter per minute. And then we will take this flow into the area equation. So the valve flow, we can get the valve flow. The valve flow is 162.6 and then divided by the K, right? K is 44.3, and then the C is empirical constant, which is the aortic valve. We are going to find the aortic valve area. So the aortic valve has 3 leaflet, right? So the constant C would be 1, right? After that, multiply with the square root of mitral valve gradient, 58 here. So the final is aortic valve area calculation is 0.48 square centimeter. That is the Gorin equation, but actually we can use another simplified version or to find the aortic valve area by using the Hughes equation. This is the very simple equation that you can use during monitoring the case, but not that accurate as the Gorin equation. Okay, the Hughes equation we can calculate by aortic valve area of valvula equal cardiac output, and then divided by square root of peak or mean transvalvular gradient. For example, if we have a patient with an aortic pressure of 120 and 60, left ventricular pressure of 170, 15, cardiac output of 3.5 liters per minute. What is the aortic valve area? If we use the Hughes equation, definitely AVA equal cardiac output divided by square root of peak or mean transvalvular gradient. The cardiac output is 3.5 liters per minute, right? Okay, and then divided by the square root of peak or mean, and the information that we get from the question is that aortic pressure is 120, which is the systolic pressure, and the LV pressure is 170. So we're gonna have to find the difference between the systolic of the LV pressure and the aortic pressure. We can get the value of here, right? 170 minus 120, and then the AVA will be equal 0.49 square centimeter. Can you see that? It's very simple. Very simple, more than the Golin equation like this. Okay, this is the normal value area ranges that you can, if you want to remember or memorize about the normal value, you can memorize all of this, that the normal value of the aortic valve is around 3 to 4, pulmonary valve 2.5 to 3.8, mitral valve 4 to 5, and tricuspid valve 8 to 10 centimeter. Okay. This is a worksheet for determination of valve areas to make you more easier to calculate the cardiac output and to follow the steps to find the mitral valve gradient and area or something like that. Okay, this is an example of the worksheet. Okay, next let's talk about valvular regurgitation. Again, the regurgitation valve, you're gonna have to focus the preceding chamber and the following chamber of that valve you are focusing on. For this, we are focusing on about the aortic valve because we are looking for aortic valve regurgitation. So the preceding chamber is is left ventricle. Yes, and the following chambers of the aortic valve is aorta. Okay, so let's take a look at the picture on the left side. During aortic valve regurgitation, you're gonna have to think. You're gonna have to think of which phase of the cardiac cycle will be impacted on. At this phase, about aortic valve regurgitation will definitely occur during diastole, right? During the ventricle in the diastolic phase. So let's imagine during LV relaxation or during the diastolic phase, there is some blood going black from the aorta into the left ventricle. So LV end-diastolic, I mean about the end-diastolic pressure of the left ventricle must be increased at the higher volume inside the LV from during the diastole. But actually, definitely during LV diastole, the volume, the blood will come to LV from the left atrium, right? And for this disease, the another volume is coming from the aorta, from the blood, from the blood leakage into the left ventricle. So during the diastolic phase, the LV, we are talking about the left ventricular end diastolic pressure, the volume, the higher volume, definitely the higher pressure inside the end diastolic pressure. So you will see that the LV EDP is increased from 10 to 20, right? And definitely after the LV EDP is increased, the LA must generate more pressure in order to overcome the pressure in the LV in order to pump out the blood inside the LA into the LV. Okay, so that's why the LA pressure is increased following then. Okay, the same idea that with the Frank-Starling rule, while the RV diastolic, the left ventricle has more volume, definitely it will be able to contract more functionally. Let's say about if it is capable to pump out the blood more than the normal, you will see about the systolic pressure. The higher blood volume inside the LV will affect the higher or the capability of the contraction of the LV, cause the systolic pressure is more higher from 120 to into 160 like this. Okay. Again, the systolic pressure is more higher than normal, and the diastolic pressure of the aorta is reduced as well because of the blood go back into the LV during the diastolic phase, so it will cause the wide pulse pressure during the systolic pressure and the diastolic pressure. You will see about this. If you find the pulse pressure, you can use the 160 minus 60. The pulse pressure is around 100 millimeters of mercury, right? And in the normal one, the pulse pressure is around 40. You will see this is an impact of the aortic valve regurgitation on the pressure of the aorta. You will see that there is a wide pulse pressure, and again with the LV pressure, the systolic pressure will increase, and the LV EDP will also increase as well due to the LV EDP is increased. Okay. You will, this is the tracing showing you about the patient who has aortic valve regurgitation. You will see that the pressure of the systolic pressure of the aorta, aortic systolic pressure of the aorta and the diastolic pressure of the aorta, you see that is quite wide. This is a sign of a sign of aortic valve regurgitation, wide pulse pressure. Okay. Next, let's talk about the mitral valve regurgitation. Let's say, okay, imagine we are focusing on the mitral valve regurgitation while we are focusing on the systolic phase, right? Because you will see the mitral valve regurgitation while the left ventricle is contracting or pumping out the blood, and there is some blood going back into the left atrium. So the preceding chamber of the mitral valve should be left atrium, right? And the following the mitral valve is left ventricle. If you are focusing on the mitral valve and you know that it occurs during the systolic phase, you can just forget. When you look at the diagram, you can just focus on the systolic phase over here. Okay, well, let's take a look at the picture on the left side first. The mitral valve regurgitation, the first chamber that would be affected is that the LA chamber, because the volume coming back from the LV into the LA, so the left atrium must try to dilate itself in order to receive the blood from the left ventricle. The higher volume, definitely the higher pressure inside inside the left atrium. Okay, with that, you will see that the pressure in the LA pressure is equal to the LV EDP because there is no obstruction between the mitral valve. So obviously, the LA should be equal to the LV EDP. So that's why the LV EDP is increased from the 10 to 25 because of the pressure, the higher pressure in the LA come to the LV, and the more volume come to the LV as well. Okay, and then there is nothing happen during systolic phase between aortic valve and left ventricular pressure because there is no aortic valve disease over here. So the systolic pressure will be equal to the aortic pressure, but you will see a bit lower. You will see about the pressure is a bit lower than the normal patient because of, let's say, about the Frankenstein law again, because the LV volume during the systolic phase the blood, that is the blood going back into the LA, not the whole blood will be pumped out into the aorta. So that's why the LV cannot pump out the blood with the same pressure, with the same pressure as the normal one, because of the lost volume into the LA, not the whole blood in the LV, and then be pumped out into the aorta. Okay. Let's see about this one. We will be able to see about the systolic phase, right? The pressure the systolic phase, and you see the change of the pressure of the left atrial pressure of the V wave of the LAP over here. You will see it's quite taller than normal, because the V wave represents the atrial filling, right? The atrial filling during the left ventricular injection, right? Because LV inject the blood into the systemic circulation, the blood will go to the lung, and the blood in the lung will come to the left atrium, right? So when we are looking at the LA left atrium, that at this phase, we will see that the left atrium will receive blood from the lungs, and the blood will the LA will receive more blood from the left ventricle during pumping as well. So that's why the V wave is taller, just like this. The V wave will be around at the end of the downslope, near the downslope of the LV EDP, or of the LV pressure, around here, something like that. Okay. This is the tracing of the mitral valve regurgitation. You're gonna have to, but actually it's quite hard to find which wave is A wave, C wave, or V wave. You just gonna have to find the first. You're gonna have to find that which waveform correlates to the EKG. Definitely, after the T wave is the N systole, right? N systole is over here, so it will align with the downslope of the left ventricular pressure over here. So if you remember that the V wave of the left atrial pressure waveform, it will be near or on the downslope of the left endoarterial pressure. So this waveform in the circle could be V wave, that showing you about the impact of the mitral valve regurgitation on the left atrial pressure waveform, like this. So just like you can imagine, you can remember that you can remember that the mitral valve regurgitation with the threshing pressure, you will see the giant V wave at the downslope of the left ventricular pressure waveform. Okay. Here is the example of another mitral valve regurgitation from caudate tendinate ruptured. You will see that very severe because it causes the very big giant V wave here. Okay. And again, when we want to look at the tricuspid valve regurgitation, we just change the label, as I said before. Okay, it will the abnormal pressure waveform will occur at the V wave over here. As I said, that the V wave will be on or near about the downslope of the RV or LV pressure. Okay, almost done. Okay, the last part is about ventricularization and damping pressure. We are gonna get through this briefly about the changing pressure that can happen anytime during catheterization. Let's say during the doctor is trying to engage the ostium, let's say the ostium of the coronary artery. If the doctor cannot choose a suitable diagnostic catheter or a guiding catheter, sometimes you will see the damping pressure on the screen. Okay, for example, just like this tracing from the aortic pressure, maybe at this period, the doctor may be doing something just like to engage the coronary ostium or something like that, and the catheter that it caused the catheter placing or leaning on the wall and cause the pressure the pressure inside the aorta cannot get inside the diagnostic catheter properly, so that why the pressure is showing you just like this. If the pressure showing you like this, you're gonna have to always notify the patient, notify the doctors that pressure is damping, to let the doctor know and just try to re-engage again. Here is another aortic pressure and damping during maybe engaging the coronary ostium. Here is the detail that you can study by yourself. As I told you about the damping pressure can happen if the doctor use in an appropriate place the catheter not in the correct position, or use the catheter with the wrong size, something like that, and after engage the coronary artery, that makes the catheter, the size of the catheter as the size of the ostium that block the flow from the aorta into the coronary artery, so that can cause the damping pressure. the last one, let's say another one, ventricularization pressure. It's quite different from the normal damping pressure, because you see that the damping pressure here, the characteristic of the waveform looks like the ventricular waveform, but it's not the LV pressure waveform actually. Okay, but how can happen? How can it happen? Okay, let's say if the doctor used the catheter as the same size as the coronary vessel, and then during engagement of the catheter into the coronary artery, the catheter go deeply inside the coronary artery and block the blood flow. I mean, block the blood from the aorta, the oxygenated blood from the aorta into the coronary artery. So the blood cannot get into the coronary artery. It let's just say completely block gash. So the pressure that is detected by the tip of the catheter will do the activity like the ventricular function is functioning. For example, so this is just like the waveform of the ventricular activity, just like a pump and relax, contract and relax, contract and relax, contract and relax, something like that, without any new blood flow into the coronary artery. Just like so that why, just like imagine about you are blowing up the balloon without breathing from your nose. You just like blow the balloon with your mouth, only with your mouth. You will just use the same air from your lung into the balloon over the time. Okay, just like that, the activity of the ventricularization pressure will represent the activity of the left ventricle is doing at that time, not the real left ventricular pressure inside the real left ventricle. Okay. Okay, the last one, the pressure damping by air bubbles can appear like this. The air bubble maybe will obstruct the pressure inside the pressure transducer or along the way from the manifold that connect the pressure tubing from the manifold into the pressure transducer. If there is some air bubbles, there are some air bubbles inside that tubing, it may cause the pressure waveform like this. And you're gonna have to notify the doctor that there is air bubble inside the system. So you're gonna have to help the scrub to reflushing the tubing or to flush the air out, to get rid of the air inside the system and zeroing the system again. Okay, finish. Anybody have any questions?
So, does anyone have any question to ask Himaj? So I think it's so does anyone so I think there's no question for now น่าจะยังไม่มีค่ะพี่หมาตอนนี้
Yeah, ขอบคุณครับ Okay, thank you for your attention. If I have done something wrong, I'm gonna have to apologize about that because I was quite blurred today because of the hard working.
So thank you very much Ella, for today's lecture. We really appreciate having you with us today.
Thank you so much. And but if anyone has any question after the class, you can leave some questions with Pichai. Okay, and Pichai will contact me again.
Thank you very much again for today.
Okay, thank you.
ค่ะพี่หมา
ขอบคุณครับบ๊ายบายนะครับ
ขอบคุณค่ะ
ขอบคุณค่ะ
thank you ค่ะ
ครับขอบคุณครับ